So I'm going to be discussing rosacea and cardiovascular disease, and this is an updated systematic review. We discussed the disclosures. So, these two talks were not intended necessarily to be linked back to back, but I do want to take a moment to highlight again something I mentioned earlier, which is the kind of clinical heterogeneity of rosacea. So there's different clinical phenotypes that may be seen, whether it's the erythematotelangiectatic, ocular, phymatous, or papulopustular phenotypes. And the fact that this presents so differently really should give a hint into the fact that this is very complicated, and the fact that it affects different, components of the face, eyes, as we see potentially GI system, really suggests a very complicated disease. So, I think increasingly rosacea is being recognized as a systemic disease rather than limited to the face. One of the links that has been identified is with neurologic disease as well, which I won't touch on now, but there have been a number of studies suggesting that, kind of similar to what I mentioned with the GI diseases, that neurologic diseases are increased many neurologic diseases are increased in patients with rosacea. GI system, certainly we just talked about. And, there has been suggested to be a link between rosacea and cardiovascular disease as well. And I think that there are two kind of sort of background components to rosacea that make this question an interesting and important one. The first is that chronic inflammation is known to play a role in cardiovascular risk. And in rosacea, there is a component of vascular dysfunction and dysregulation that may suggest also that it has an impact on cardiovascular disease and cardiovascular risk as well. Just as a brief point, I really want to highlight the fact that inflammation is linked to cardiovascular disease. And I think this was really, say, maybe even proven, or at least semi-proven, with a study using anti-inflammatory treatment, which reduced the incidence of secondary or second event cardiovascular events in people that was unrelated to lipid lowering levels. So inflammation increases risk of cardiovascular disease, and decreasing inflammation decreases risk as well. So I mentioned this is an updated systematic review, and a few years ago there was this prior systematic review published showing a likely link between rosacea and elevated blood pressure, dyslipidemia, insulin resistance or diabetes, and cardiovascular disease more generally. This was done a few years ago, and so there have been a number of studies published since this was done, so we wanted to update the literature in that regard. So performed a systematic review and ultimately identified 17 studies to include that shed light on this potential link. As you can see, most of them were case control studies, a few cross-sectional, and then one each of a cohort and a GWAS study. So I'll first touch on what these studies have shown in regards to diabetes. And so there were findings of a significant association between the severity of rosacea and fasting blood sugar levels. That was higher in severe rosacea patients than in more mild patients, again suggesting sort of a dose-dependent effect potentially of this inflammatory process. There was also a significant association a second study found the same or similar significant association between the severity of disease and fasting blood sugar. There was also a higher proportion of rosacea with insulin resistance compared to controls in two studies as well, suggesting a link with, in this case, metabolic disease. Hypertension is a little bit more of a mixed bag. There are some studies that identified either increased rates of hypertension or increased systolic and or diastolic blood pressure. These are the ones listed here that demonstrated this association. The other studies did not, so I think it's a little more equivocal as to whether rosacea really is associated with elevated blood pressure. A few studies looked at maybe more direct measures or at least imaging measures of cardiovascular disease, and so this was a couple of studies looking at carotid intima media thickness, In 2 studies, there was increased thickness. In another one, there was not. Again, suggestive of a link, certainly not definitive here. There was no association found in ankle brachial index, and there was some increased epicardial fat thickness in rosacea patients as well. Perhaps not surprisingly, for something that is increasingly, as I mentioned, recognized as a systemic inflammatory disease, most studies found elevated CRP in rosacea patients compared to controls. A little more mixed results with ESR, although the number of studies that assessed this were lower. There were also found in one study to be significantly elevated odds of VTEs and VTs in patients with rosacea after the diagnosis. So, potentially, again, thromboembolic events may be increased as well. And I apologize, this is a little bit kind of repetitive just in the nature of this, this kind of study, but I'm kind of wrapping up pretty soon. So 4 studies here found no elevated risk of cerebrovascular or cerebral infarction in rosacea patients. There was one study that did find increased risk of hemiplegia in hospitalized patients with rosacea compared to patients hospitalized with psoriasis. Again, and we're primarily comparing patients with rosacea to people without inflammatory skin diseases. I think some of the next steps will maybe be to understand the relative risks among patients with inflammatory skin diseases. And then kind of to wrap it up, just, cardiovascular disease more broadly. So again, increased risk for cardiovascular disease compared to controls in one study. And this was defined as hospitalization because of coronary heart disease or stroke. So again, significant outcomes. Another study looked at cross-sectional analysis, did not find a difference in likelihood of ischemic heart disease, but did find evidence of cardiovascular disease overall. So just in summary, taking a step back, I think overall there is some mixed evidence for different associations with rosacea and cardiometabolic disease, and perhaps this is my editorializing a little bit, I think overall the evidence does suggest that there is a relationship, and perhaps understanding it on a more nuanced level, what specific populations, what specific rosacea phenotypes, and so on may be playing a link will be important for us to ultimately ensure that the patients are treated not just for their skin, but for their overall health in the context of rosacea. So thank you very much.